So thank you. When I agreed to give this talk, I was told that I was going to be following a really boring data guy. And so that's why I agreed to do it. And so I'm completing the rest of my presentation under a formal protest.
Noted.
Yeah, okay. So it is an honor to be here. I've had the good fortune of working at Edwards for 34 years. My bio says 25 because it feels really old when I say 34. But I've got the opportunity to work on some really interesting and disruptive technology, so I'll share a little bit of that. One of the misnomers about innovation, though, is that innovation, everybody thinks that the new invention displaces something because it's clearly superior. And that's almost never true. The new invention almost always is inferior to the original invention, but it brings something else to the table. And oftentimes that's convenience or a user experience or something else. I remember I have twin daughters, and when they were little, I lugged around a 35 millimeter camera, and that was something that you actually had to buy film for. For some of you in the audience, film is something we used to put in cameras. And we used to do that, and then you actually had to take them somewhere and get them developed, and then you'd get double prints, so you had one copy for somebody else. And that's just the way it was done. But the picture quality was amazing, and still today, 35 millimeter cameras still have the best picture quality, but very few of us have any pictures anymore on 35 millimeter cameras, and most of you don't know what film is, because the iPhone and your mobile devices have become the way that everybody takes pictures, and it's not because they were superior, certainly not in the early days, they were not good at all, but it just the convenience factor of having it with you all the time is what drove that. So innovation oftentimes is something that's very, very inferior, but it leads to it. So I'm going to talk about the kind of the evolution of heart valves. I'm going to try to take a very long story. I'm going to try to make it shorter. So this is sort of the evolution of surgery and surgical heart valves. And this is the business that I sort of grew up on. And we start out with a big open chest incision, and then we got to progressively smaller chest incisions. And that was kind of the innovation. And this happened over 60 years. And everybody kept trying to figure out how to do the same basic procedure, but through a little smaller incision, a little bit better, and there was sort of a lot of incrementalism. And then we sort of jumped in and we tried something that was incredibly disruptive, which was a transcatheter valve procedure. So this is our latest technology, our SAPIEN 3 device, and I'll show you about a little bit what this looks like. But we actually have the ability now to replace someone's heart valve with no chest incision in under 30 minutes. So here's what we do. First thing we do is typically we bring a balloon up, and we bring it up through the leg, through the femoral artery, and we bring it up to the diseased aortic valve. It's very calcific. We inflate the balloon, and so we sort of pre-dilate the valve. Now, I will tell you, we don't even have to do this in probably 50% of our cases now. We just come in straight with our delivery system. But after we do the pre-dilatation step, we introduce our valve. And it's a valve, and you'll see the valve there, and it actually sits on a rail, and then we'll actually bring the balloon back into the valve. And the reason that we do that is by having the valve off the balloon, we're able to keep the profile as small as possible so the incision in the leg is as small as possible. Then we'll drag the balloon back into the valve, and now it's mounted. We actually do that in the body. Once that's done, we advance the device. The system actually articulates, so we try to do our best not to touch the aortic wall. We don't want to break off any plaque or anything else. So we can articulate the system across the wall, try to center it as best we can. Then we bring it to the diseased valve. We anchor it here. We adjust for final positioning. Get it where we like it. And when we think we really like the positioning, one of the things we want to do is we want to put the heart into cardiac standstill. So we actually turn on rapid pacing. We make the heart beat very quickly, 160, 180 beats per second. You'll see that start in just a second. There's the heart's beating very quickly. We inflate the balloon. We push the diseased valve out of the way. The new valve anchors into all that calcium. We deflate the balloon. We pull the whole system out. And you just watch somebody get their heart valve replaced. We routinely did this. I was at a medical meeting recently. They did the procedure skin to skin, 12 minutes. Patient went home the next day. We now have a bunch of patients that we actually send them home the same day. And I was actually at a meeting last night. We had a proctor meeting, and I asked one of my clinicians from Canada, John Webb, who's been a real innovator in this space. I said, what do you think about sending people home same day? And he says, oh, I don't know. I goes, I guess you could. But if I think if you replace someone's heart valve, you should at least buy a breakfast. And probably seems like a fair rule. But this has been a long journey, an incredibly long journey. And you can see it's been a real evidence-based journey. The first procedure was done in 2002, but there were very few procedures done in the subsequent years after that. But this actually, the research that's been done in this space has led to 4 separate New England Journal of Medicine articles and a couple of Lancet articles when this has been very disruptive technology and very challenging. But the first generation technology wasn't necessarily the best. The first thing that we looked at actually was inoperable people that couldn't have surgery. And we just felt that's where the risk benefit would be most profound rather than take on patients that do very well from surgery. And what we showed at a year was there was a 20% difference in absolute mortality, 20%. So that's not like I'm not poking at pharma, but I'll poke at pharma. When they say a 20% reduction, they'll say, something went from 5% to 4%, and they'll call that 20%. We're saying something went from 50% mortality to 30% mortality in a year. But the 50% is the real remarkable number. 50% of people who had severe symptomatic aortic stenosis died in a year, which is rarely how we think about heart disease or how we think about aortic stenosis, because the current pathway for treating it is often watchful waiting until they decide the patient is sick enough to undergo open heart surgery. And that's a hell of a thing to do when somebody's got a 50% mortality rate in a year. Could you imagine doing that with cancer? I have this big mass on my lungs. Well, when you start coughing up blood, come on back and then we'll take a look at it. We don't do that in any other part of medicine, but that's what we do with heart disease. And a big reason because of it is because the therapy was open heart surgery. And when the therapy is open heart surgery, people are reluctant and they have to wait and they have to be really sick before you can convince them to have their chest cracked open. But with the advent of transcatheter valves, we can totally change that. All we have to do is just educate the world and educate the patient population that this exists. We then did randomized trials where we compared this to surgery, and we showed that there was no difference in having your valve done through a catheter versus having your valve done for surgery. And we looked at the hemodynamics, and the hemodynamics, the end result was actually a little bit better, but statistically indifferent than open heart surgery. Our first generation device was quite large. It was clunky. We only had 2 valve sizes, but we continued to innovate. We added another valve size for larger patients, and we took the profile of the device down. 24 French, 22 French is quite large. We got down to 16. Now the device that we have is a 14 French device, so it's quite small. The device is much more sophisticated. You can actually see there's a little bit of a fabric skirt around the bottom that prevents leakage from around the valve, which is really important. And now when we look at our current generation of transcatheter heart valves, we are 4 times safer than surgery. At 30 days, the risk of having a stroke or or dying is 4 times less with a transcatheter valve than it is with having open heart surgery. So you have to live through that early innovation phase, but then the new innovation can actually turn out to be better. So when we run these trials, though, these trials are big, they're randomized, they're very, very expensive to do. But you look at the endpoints, and the endpoints for these trials are all-cause mortality, all stroke, moderate or severe aortic regurgitation, okay? Now, I don't know the last time a patient's walked into a doctor's office and said, my major concern is moderate or severe aortic regurgitation. It's probably not the thing that they bring up. Death and stroke, they probably understand a little bit better. But the funny thing is we negotiate these with FDA, and they're great clinical endpoints, and we're very proud of them. Death is a particularly good endpoint because it only takes about 5 people on a clinical events community to adjudicate it and decide whether a patient really is alive or dead. But we did a really funny thing. We went out and asked patients what mattered to them. Only 7% of patients who were going to undergo this procedure said staying alive was their number one concern. 7%. So our primary endpoint, the number one hierarchical endpoint that we have in our thing, 7% of patients cared about. We asked them what they did care about, quality of life. And there's been some patients who have actually, I've been in the room with our investigators when they're screening the patients, they're talking to before they undergo the procedure. And oftentimes the patients will say the oddest things. They will say, look, doctor, if I die, I just want you to know I forgive you and I appreciate you trying. But please just don't leave me with an incomplete recovery. I can't live the way I'm living. So if this doesn't work, that's okay. But I just want to feel better. And ironically, in most of these clinical trials, how the patient feels is not captured in any of the primary endpoints. We now begin capturing the secondary endpoints, and this is a major part of what we do in these trials now, is we start looking at the things that really matter to patients. One of the second things that matters most to patients, especially elderly patients, is being able to live independently. Nobody wants to go to a nursing home, and a clue for all of us, they don't want to come live with us either. And because this is payback from when we were kids, and we're going to start telling them what to do. And nobody wants that. And they don't want to lose their driving privileges. They don't want to lose any of those things. They just want to be able to live independently, and they want to live with dignity, and they want to live with respect for the rest of their life. And those are things we often don't measure and don't study in a clinical trial, and those are the things that are most important to people. And we just have to simply get better at this. These are getting a little bit deeper into the data. Half the people said, I want to resume an activity I used to do, whether it's going to the driving range, whether it's crochet. When people have severe symptomatic aortic stenosis and they're in NYHA class 4, it's so bad, doing something as simple as brushing their teeth will wear them out. It's hard for them to carry a conversation. They can't even play cards anymore. They can't do even some of the most basic things. And they want to go back to do one activity. And oftentimes it's just living to a milestone. I want to get to my grandson's wedding. I want to be able to dance. I want to be able to do this. Maintaining independence is a big one. Reducing pain or symptoms, and again, staying alive is kind of the minimum one. Here's another thing of TAVR that we never looked at from surgery. In all my years of doing surgical research, we never asked, we always talked about the patient getting discharged from the hospital, but discharge from the hospital is not the same thing as going home. So we started looking at, how many patients do we send home, and home is the home they came from, not some rehab center. 62% of our patients, and these are patients that have elevated risk. The average age of these patients was about 80 years old. So these are pretty elderly people. 62% of them that had TAVR went home versus only 28% who had surgery. And when you look at home health, now you get another 22%. So 84% of patients that had TAVR either went home independently or they went home with somebody coming into their home and providing periodic nursing care. And that is so important for this patient population that we're treating, but frankly, it's probably important for almost any patient population. If you're gonna have a procedure, even if you're young, do you wanna go home or do you wanna go to a rehab center? You wanna go home, you wanna be in your own bed, you wanna be able to have that, and that's one of the big advantages that TAVR offers. So TAVR, I always say it's the unicorn. It's safe, it's effective, it extends life, it improves the quality of life, it's cost effective, it's got a very short procedure time, faster discharge, faster recovery. So it really is one of those unique technologies. Technology drives significantly value. Certainly, though, systems reward it, right? If you can do something like this, it's so much better, it's so much safer, it has so many benefits for the payers must be just jumping through hoops to be able to figure out how to pay for this. Well, that's not how our reimbursement system works. So if we look at the reimbursement for TAVR that's happened over time, the reimbursement has actually gone down by 14%. And the reason it's gone down is because people leave sooner, they have less complications, and the healthcare system is designed to pay for the use sources utilized, not the value of the procedure. So TAVR is getting cheaper, but it also means hospitals are getting less and less for doing TAVR. Surgery, ironically, is actually getting more expensive. So if this system applied to the restaurant industry, when you order something at McDonald's, the longer it took them to give you your food, the more expensive it would be. That's really the analogy. I mean, it's just such a silly system. If we flipped the system and said, hey, you get $100,000 for treating aortic stenosis patient, but it has to last you a year, now all of a sudden reducing complications, reducing length of stay, reducing rehab, those things all come into play because that's a value-based system versus a resource-based system. But this is what we're living in right now. And so TAVR is now, and if you look at the total cost for a year, TAVR is $15,000 cheaper than doing surgery, but hospitals make less money on it. And those two things are in direct conflict with each other. So we can solve society's ills, but we're having a hard time doing the hospital economics. So just talking a little bit about innovation, a lot of people point to Edwards and they talk about our transcatheter heart valve. And at the time that we did it, nobody thought this was going to work. It was very risky. It was very disruptive. What nobody talks about is all the things that we invested in that didn't work. These are all technologies that we literally spent hundreds of millions of dollars on, and they never came to the light of day, because when you have a real innovation strategy and you start, you don't know what's going to work and what's not going to work. And so these are all things that we did. A couple of these projects were mine, and it's really painful when you go into your boss and say, hey, that $100 million you gave me didn't work. And it gets reflected in your performance appraisal, trust me on this. So that's a scary thing, but you can do it. If you hit a home run every decade, then these are things that you can do and you can make these big investments, but it's critical that we have an ecosystem that allows you to benefit from those. So I always think about the innovator's dilemma. This is one of my favorite pictures. This is a young Dr. Albert Starr, who was the surgeon who was really behind the first commercial surgical heart valve, and this is in 1964. And he had done the procedure on this mother of three, and he is obviously very emphatic. And the thing I think about is in 1966, can you imagine two things I think about with this picture? Can you imagine just the pure euphoria of being able to cut open somebody's chest and replace their heart valve that you invented, and then have that patient come back in for their follow-up and return a mother back to their family, the euphoria that must have been. And the second thing I think about is how different the sexual harassment rules were back in 1966. But we have the agony of the feet. We kiss a lot of pigs. We do a lot of things that turn out not to work at all, and they don't work, and you're trying to explain it later about why you really thought it was a good idea. The problem is you don't know what's what until after the money's already spent, until after you've done the clinical trials, until you've actually figured out. But here's what happens when we stop fighting for innovation, and this is something that's critically important. There tends to be a tendency as technology gets more mature to try to commoditize it. When we commoditize it, we try to drive all the cost out of it we can, and we negotiate, and we grind everybody, and we go through that whole process. But what happens at some point is you take all the profitability out of a procedure, then you take all the investment out of the procedure, and you take all the investment out of the innovation. So this is the heart-lung machine. This is the machine that keeps you alive, keeps your brain alive while you're having open heart surgery. Who in the room feels that that looks state-of-the-art? This is a modern heart-lung machine. It has not changed in 20 years. There are miles of tubing here. Every blood cell that hits tubing is bad, and we have to pump drugs into people to keep their bloods from clotting up through all this mechanism. Are you telling me there's no opportunity for innovation in this space? Of course there is. There's tremendous opportunity in innovation. Nobody is doing it. Why? Because the prices got taken down so far in this space that there's no money to be made in this space, and no one is investing in it. We had a cardiopulmonary company. We did $300 million in sales. We sold the company for $30 million, and I promise you, we took them because it was a bad business to be in. It was like a boat anchor on our P&L. And so we have to find the balance of being able to reward innovators and make sure that they can continue to invest in this space while at the same time trying to figure out how to reduce costs for the healthcare system. But I absolutely believe technology is the answer. Like TAVR, we had to go through this phase. In the early days of TAVR, full disclosure, it was more expensive than surgery. But if you let it develop 10 years later, it's cheaper than surgery, and we save society $15,000 every time we do TAVR versus surgery. So we have to let the ecosystem develop those things and be able to move it forward. But again, we have to line the incentives. It can't be a matter of the longer it takes to get your food, the more money you get. It can't be the procedure that has more complications and longer lengths of stays and more rehab gets more money than the procedure that's safer and more efficient. That's just a silly way to run the healthcare system, and I hope that we can make that better in the long term. So thank you very much.